Alzheimer's Australia has recognised for some time that increasing numbers of people with disability are being diagnosed with dementia.
And that's helping with the pain? Yeah. Oh, good.
Dementia may be prevalent in the older population, but it is indiscriminate and can affect people across all generations within our lifespan. People with disability are living longer due to greater access to quality healthcare, improved living conditions, and increased social support and participation. And as a result of this longevity, people are experiencing age-related diseases, illnesses and conditions, of which dementia is one. With funding provided by the New South Wales Department of Family and Community Services, we have developed this resource to provide information and understanding of dementia for those who are working and caring for people living with dementia and intellectual disability. Here at Alzheimer's Australia, we have a philosophy of inclusive, enabling and person-centred approaches to supporting people with dementia and their families and their carers. We hope this DVD in some way helps to support you in your workplace.
Dementia is not one specific disease, but is a broad term used to describe a collection of brain disorders which cause decline in memory and thinking skills. For most causes of dementia, symptoms gradually become more severe over a number of years, so that thinking, behaviour, mood and ability to perform everyday tasks are increasingly affected. At later stages, dementia affects basic bodily functions that are necessary to sustain life. There are many different causes of dementia, and all involve damage to and eventual death of brain cells, affecting the capacity of the brain to function properly. The most common cause is Alzheimer's disease. Other common causes are vascular disease, Lewy body disease, and frontotemporal dementia. Some of the less common types of dementia include dementia due to traumatic brain injury, Parkinson's disease, substance use, or certain brain infections. Sometimes different causes occur together in the same person, for example a mix of Alzheimer's disease and vascular disease. We know that people with Down syndrome have an increased risk of Alzheimer's disease associated with the additional copy of the chromosome 21. We also know that people with intellectual disability, regardless of the cause, appear to have an increased risk of developing dementia. Often, health and healthy lifestyle issues are overlooked through the lifespan of a person with an intellectual disability, and it could be that these factors explain some of the increased risk for the development of dementia in people with an intellectual disability. The person with an intellectual disability might express concern about difficulty with memory and thinking.
Just let me know how the leg's going, won't you?
How this is expressed will depend on the person's disability and communication skills.
Oh, how's your neighbours going? Swimming in the pool? Yeah. Oh, that's
Sometimes changes will first be noticed by others who support the person, particularly those who've known the person well and have a clear understanding of their usual level of skills and functioning. Some of the changes that may be noticed include a gradual loss of memory or other thinking skills, loss of conversation and problem-solving skills, changes in personality, periods of inactivity or apathy, not wanting to participate in activities that they've previously enjoyed, gradual loss of skills and independence, and over time deterioration in self-care skills, such as no longer being able to shower independently or effectively, loss of previously attained continence, or the onset of seizures. A thorough assessment for dementia is important for a number of reasons. There are a number of other health conditions that might look like dementia, but which are treatable. Some of these are mental health conditions such as depression, psychotic disorders, or reactions to stressful events. Some of these are medical conditions such as thyroid diseases, epilepsy, severe anemia, vitamin or mineral deficiencies, various metabolic disturbances including diabetes, or delirium, in which a medical condition causes a person to quickly become confused or disoriented. Sometimes, a person's medications may also be contributing to decline in memory and thinking skills. And, if recognised and adjusted, these changes can be reversed. If a diagnosis is made, it enables a person and others involved in their life to begin planning for future support as it progresses. If the person is living in a supported environment prior to the diagnosis, there will be a need for increased support over the progress of dementia, such as night support or more one-to-one assistance rather than group support. The service organisation will need to think about staff ratios and training, as well as the impact of the environmental factors on the person. It can also be helpful to gather information from the person and their family about their life history. As dementia progresses, the memories that will be more accessible are those from the past. An understanding of the person's history can help those around them recognise what might be important for them at any given time.
If we feel that a client is starting to show the signs of dementia, we contact our dementia advisor who is in the area, and she will then make a home meeting and contact the family, and even with the case manager within our organisation, we'll have a meeting and we'll start the process of visiting and trying to get a diagnosis.
We need to look into it. And again, keeping those fluids up in this hot weather.
Organisations who work with people with an intellectual disability have often started putting plans in place for people with dementia. They may have increased staffing available when someone develops dementia, or staff that can be awake overnight to support the person, or they may have programs or activities available for people who can no longer be involved in a work-related role.
And she been taken to the social support to craft it.
That's good. Thank you.
A diagnosis may be required before the person can access some of the services and supports that are specifically for people living with dementia. A number of factors make it harder for a person with an intellectual disability to access appropriate and skilled assessment and management of dementia. The person may themselves have difficulty expressing their concerns or symptoms. Those around them may assume it's the disability or ageing causing changes in the person's ability or behaviour. Professionals may lack knowledge, skills and experience in assessing people with an intellectual disability who also have dementia. As dementia represents a decline from the previous level of memory and thinking skills, sometimes the lack of clear documentation of the person's usual level of skills in these areas is lacking, making it hard for professionals to make a judgment on whether there has been decline. In addition, factors which can cause a change in the person's functioning and thinking, including some specific mental health conditions and medical conditions such as depression, stress, epilepsy, hypothyroidism or other medical problems, are more common in people with an intellectual disability. And this complexity and the need to exclude such factors before making a diagnosis of dementia can sometimes be overlooked. A GP seeing a patient with memory or other changes might screen a person for indications of dementia. However, for a firm diagnosis, most people will need to see a specialist, such as a geriatrician, neurologist or psychiatrist. For someone with an intellectual disability, it can be easier to see a specialist who understands both the disability and dementia, such as a specialist developmental disability health or mental health service. Making a diagnosis of dementia usually means that the person with an intellectual disability will need to have a detailed assessment, medical examination, medical tests, and tests of their thinking and memory skills. Detailed information is also required from someone who knows the person well, such as a family member or a long-term carer. This person may be asked a series of detailed questions about the person with an intellectual disability, including about changes in thinking skills, everyday skills, and their medical history. The person will need to consider planning to use support services as the dementia progresses to assist with maintaining social engagement, personal care or transport.
My role in our organisation is to go out to, as a care community worker, and I go out to our consumers' homes and provide services for them. It could be social support, it could be medication monitoring, it could be for personal care, it could also be for any domestic assistance within their home.
We'll try and, as much as possible, enable the person to keep going with their everyday activities.
Oh, look, pussycat. Yeah. It's not like your one, is it? It's got pretty colours.
But I guess my biggest thing is that they lose their confidence, they're starting to realise that they are forgetting certain everyday things, just being able to wash up or make a cup of tea or just little things. And as they're realising that these things are happening, their personality starts to change, or they become less confident.
We'll have a little bit of a breather, get your energy levels back up. Oh, we've picked up a dog on the way. Yeah.
The carers are generally already experiencing burnout by the time they know about our services or are being provided with our services. So, for them, they are relieved that there is someone coming into their home that can provide the care for their son or their daughter.
And I hope when I get to a stage where I need some help that there's someone there to support me and to keep me in my home as long as I can.
Alzheimer's Australia New South Wales has information through the National Dementia Helpline and also on their website about dementia and many aspects of dementia. We can also provide education to organisations, to families, or to the person themselves about what's happening, about the changes that are occurring. If those close to the person with dementia are having difficulty understanding what's happening or knowing how to support the person, they can also make an appointment to have counselling. We have a free counselling service at Alzheimer's New South Wales. And this is also available to somebody with a diagnosis if they're able to interact with the counsellor.
What else is happening? Oh, not very much, no.
If the person with dementia is under the age of 65, they can access support from our Younger Onset Dementia Key Worker program.
The Younger Onset Dementia Key Worker program is a program that enables carers, people with dementia and service providers to access the support in the form of a key worker that can guide them and support them through the available services, education, information they may need in relation to younger onset dementia. To get in contact with somebody in regards to the Younger Onset Dementia Key Worker program, the best way to do that is through the National Helpline, which is 1800 100 500. With that early support, the person with dementia, with an intellectual disability, will have a really good opportunity to be able to make their wishes for the future known and let their wishes be known around support and planning for the future the way they want it to be.
One of the ways that the Key Worker program can assist is to provide staff training and support and resources around how to work effectively and support clients in their community or in their group homes. And we can work with staff and teams around some of the most appropriate strategies to continue to provide that client with the support they require to continue to live in the community.
No, Brooks doesn't get to go anywhere either. She stays here and looks after the...
Most people that ring our National Dementia Helpline and are referred to our intake officer or who perhaps maybe speak with a key worker for the first time, one of the things that is mentioned a lot by families and carers and even the person with dementia is that they're so relieved to find somebody that finally understands and somebody that's listening to them.
She was fun, she had a great sense of humour. She was always one of those light people, that you just sort of just make life a little brighter. So she was one of those people. Gosh, she was always really stubborn. She knew her own mind. So Kay came to live with me and I noticed after a period of time that there were some differences in how she was responding to people and relating to her circumstances and her environment. There was something else, actually my older sister and I both realised there was something else going on. And we took her to a psychiatrist at Chatswood who was very familiar with people with disabilities. There were instances where she would be upset by things quite easily and couldn't quite cope, and she became a little bit more fussy, needy, and that progressed as time went on. There were a couple of little subtle differences. In her eyes, I noticed that something got switched off for a second. It was like something just switched off and wasn't working. And it could be fleeting. As time progressed, that became a little more frequent. I noticed that there was a little bit of memory loss. And as the symptoms got worse, that you were repeating things more and more often. She was around about 37 years old And I'd never heard of early onset dementia, but when I took her to the psychiatrist and I told him what she was experiencing or the behaviours that she was displaying, he immediately said, "It sounds like early onset dementia." I guess when we got the diagnosis of early onset dementia, it sort of sent us reeling sideways a bit, but because we just didn't expect it. What we then focused on was providing Kay with the supports that she needed around that, and staying in home and keeping the environment as stable as possible for her, and getting in as much advice as I could. It was really important to get that diagnosis so that I could get my head around where we go to from here for Kay. If we hadn't had that diagnosis of dementia, I suspect that I would have kept dealing with the symptoms as they arose, but I wouldn't have had the resources in place to do, or the networks in place to do that as well as I possibly could. And therefore the quality of care that Kay received would not have been as good as it would have been. So many physical aids and assistance that you need, and just knowing that you've got someone I know something that might help with that, and you go, there's something that can help with that, so just having that information is crucial, and that makes your job easier. The case manager came out and did an assessment, and from that point I was then linked into other services. And I think all those places like the Dementia Advisory Service, Alzheimer's Australia, the Memory Clinic at the hospital, all of those support services that are out there need to be accessed, and you need to take on as much help as you can. Don't be proud, don't feel like you're taking too much, just go for it, because it's all those networks that enable you to keep caring for the person that you are caring for.
The progression of dementia can differ from person to person and depends on many different factors, including the specific cause. We know that over time dementia becomes more severe, and that increasing supports will be required for the person and their carers as the disease progresses. However, few studies have been undertaken specifically for people with an intellectual disability. Generally, keeping the brain healthy by exercising the brain and remaining socially engaged, undertaking physical exercise, a healthy diet, and taking care of things like high blood pressure, diabetes, cholesterol and weight are the best ways to reduce dementia risk.
Is it?